On behalf of YACI and UCCC, I'd like to thank you all for coming tonight. We're pleased to see such a great turnout, and I'm excited to see all the presentations that we have. I'm Aisha, and Jess is also on this call. We're the co-directors of UCCC 2021, and we also have UCCC logistics officers, Amy, Charles, Jackie and Minji, and research officers, Amy, Krishnil and Chi with us tonight.
I'll have to manually press the next button.
There we go. So I'd like to acknowledge that we're on the lands of the Wurundjeri people who have been custodians of this land for thousands of years, and acknowledge and pay our respects to their elders past, present and emerging. And I'd like to extend that respect to any other lands that we're gathered on today virtually. So I invite you all to use the chat function to write a quick acknowledgement of country of your own and acknowledge the lands that you're on today. I'll pass it across to you, Jess.
Great, thank you. So UCCC is an initiative of the Young Australian Cancer Initiative, which aims to nurture a future generation of cancer literate students who are empowered with the skills and knowledge necessary to reduce the burden of cancer in our society. Our work is generously supported by our partners, the Peter MacCallum Cancer Centre, the Melbourne School of Dentistry and Health Sciences, the Walter and Eliza Hall Institute for Medical Research, the Australian Cancer Survivorship Centre, the Olivia Newton-John Cancer Institute, and the Victorian Comprehensive Cancer Centre.
This year, participants were tasked with the challenge of designing an intervention to increase HPV vaccination two-dose course completion amongst First Nation adolescents, with a maximum budget of $3 million and a time frame of up to 5 years. We would like to thank and extend our congratulations to all the teams that took part in UCCC this year. It was an incredibly difficult decision for our team to select the top 5 out of 40 high-quality submissions we received this year.
It is our pleasure to now introduce to you all our judge panel tonight. Associate Professor Julia Brotherton, Associate Professor Lisa Wobb, and Dr. Tamara Butler.
Associate Professor Julia is a public health physician and medical director of VCS Population Health. For over 15 years, Julia has been involved in research and policy development informing the implementation and evaluation of HPV vaccination programs in Australia. She has been a lead investigator in Australian research, which has demonstrated the world's first evidence of dramatic declines in both HPV infections and precancerous cervical lesions in young women post-vaccination. Associate Professor Lisa is one of Australia's leading figures on cervical cancer control in Aboriginal and Torres Strait Islander women. She is the principal investigator on an ARC Discovery Indigenous grant focused on understanding the modifiable factors that influence uptake and completion of HPV vaccination for Aboriginal and Torres Strait Islander adolescents. And Dr. Tamara is an Undambi woman and an early career researcher. She was awarded her PhD in social psychology by the University of Queensland in 2017. She's a mixed methods researcher, and her interests include improving cancer outcomes for Aboriginal and Torres Strait Islander people by understanding factors involved in participating in screening and prevention programs.
We are now pleased to introduce the 5 finalists of UCCC 2021. At your cervix, 2 shots to stop cervical cancer, the chronic overcommitters, Catechist Consulting, and HIT, HPV Indigenous Immunization Task Force. They will present in the order shown in this slide. Without further ado, let us welcome At Your Cervix to present their proposal.
Okay, shall I make a start? Okay, good evening. We are at your cervix and it's a pleasure to present our solution, Combating Cervical Cancer Connectivity. My name is Angelina and I'm joined by my teammates, James and Ava. Before we begin, we'd like to acknowledge the traditional owners, the Yorta Yorta and Bangarang peoples of the Greater Shepparton land on which we work and live. We pay our sincerest respects to their elders past and present. We celebrate their cultures, stories, and traditions as we continue our education here so that when we become future healthcare practitioners, we can better serve their community.
So first of all, HPV is the primary cause of tobacco cancers, but as we know, this is entirely preventable. We have the successful TGA-approved HPV vaccine, Gardasil, that is free for those under 19 years old. Currently, the first dose uptake is high for both Indigenous and non-Indigenous students, but the completion rates are generally lower for Indigenous students. We still have this gap to bridge, and mortality rate from tobacco cancer is 3 times higher in Indigenous women. Ultimately, identified 3 key barriers: distrust, compliance, and disempowerment. So these barriers were identified upon consulting with Visual Liaison Officers here in Greater Shepparton. The first challenge, distrust, stems from a long history of injustices inflicted on the First Nations peoples. The second, of compliance, stems from a below average year 7 attendance rate, the year in which the vaccinations are provided here in Victoria. And specifically in Greater Shepparton, the school attendance rate falls by 25% after the age of 15. Finally, empowering First Nations peoples to take control of their own health and health information is a challenge to overcome, especially due to the fallibility of a total reliance on community gatherings according to the ALOs, especially during COVID times. So our solutions we will introduce to you today are information, notification, and personalization.
Our proposed solution is twofold. Firstly, we propose the creation of a synchronized website and mobile app that is non-targeted and non-discriminatory. Our platforms will complement the current effective school immunization program and serve to streamline the vaccination process from beginning to end. Our website and app centralizes all key information regarding the HPV vaccine in one space and features an online consent process. Secondly, to increase compliance, we implemented a robust and effective notification and booking process. Lastly, to increase engagement and empowerment, there are added features to optimize user experience, especially for First Nations individuals. The second part of our solution involves conducting a pilot study. Our services will roll out in stages. First, in the Greater Shepparton area, which has the second largest First Nations population in the state of Victoria, and then subsequently statewide and in the future, Australia-wide. Conducting a pilot study has 3 key benefits. 1, it can inform us of the feasibility of our services and any modifications we need in order to make our solution scalable. 2, it enables us to refine our interventions and strategies as necessary. And lastly, a successful pilot study will help us secure more funding for expansion Australia-wide in the future.
So our first goal to overcome is distrust through the provision of clear and digestible information within our website. Our website and app will answer the most pertinent questions relating to the vaccine, including the importance of receiving both doses. Our platforms are promoted at vaccine providing clinics and schools for this ease of access information. And finally, we aim to reiterate the importance of inclusivity in defeating tobacco cancer, because ultimately everyone needs this vaccination. We believe our solution has the potential to target multiple disenfranchised groups to tackle this greater issue.
Secondly, our platforms overcome issues of compliance. Paper consent forms are a barrier to vaccination rates due to them being misplaced or unreturned. Therefore, we are centralizing the consent process and making it available solely through our platform. A link and a QR code to our website will be given during the high school enrollment process to enable parents to give consent whenever and wherever. For those that don't have internet access, they can access our website in community centers or school libraries. An additional feature are our scannable QR codes. Tracking and remembering HPV vaccine status can be difficult, so we have set up unique QR codes for the first and second dose that is distributed to each vaccine provider. After each dose, students will scan the relevant QR codes, and the receipts of the HPV vaccine will be added onto each student's account automatically. This helps families check their child's vaccine status conveniently and helps us to track progress for our pilot study. Additionally, catch-up doses are often missed. To mitigate this, we aim to notify, simplify, and satisfy needs to increase catch-up dose uptake. Parents will be sent SMS and email notification to remind them of their child's upcoming or missed vaccines. After scanning the first QR code, a reminder for the second dose will be automatically sent 6 months afterwards. And to streamline the booking process, each missed vaccine notification includes a direct link to our booking page. And lastly, to optimize the experience for our First Nations users, we have tagged the First Nations flag to each clinic that is deemed culturally safe by local community Indigenous leaders for those that wish to access these services.
To overcome our third challenge, disempowerment, we created a digital health pass with the cover designed by a First Nations artist, which allows an individual to track the number of doses they've received. Firstly, the digital health pass is superior to a traditional paper-based vaccination records and avoids the laborious process of contacting the Australian Immunization Register. Secondly, the digital health pass ensures privacy by providing end-to-end encryption, which is only accessible by the owner's username and password. Lastly, with the consent of an individual, it has the potential to be linked to health databases so that it can allow the holistic management of a patient. We have identified a major cause of low vaccination uptake is due to absenteeism, and a significant cause of absenteeism, especially in First Nations girls, lies in the lack of access to sanitary products. Therefore, with our budget, we have subsidized a one-year subscription of hygiene products for all genders in the form of a promotional code in collaboration with hygiene companies. This promotional code will be made available as soon as proof of the second dose is recorded in the digital health pass. By targeting this significant cause of absenteeism with hygiene products, it contributes to increased school vaccination attendance and simultaneously empowers young First Nations adolescents to take charge of their sexual health.
Now, for our 5-year plan, which includes these 3 rollout periods, our initial pilot study in Greater Shepparton, our Victorian rollout, and finally our nationwide rollout, each of which having 3 phases. Firstly, 6 months of planning development during which our website and app will be developed and updated with each rollout, a launch and promotion phase that coincides with when the 2 HPV vaccinations are administered, and finally a data collection and research period during which we will analyze the effectiveness of our services compared to the previous cohorts. This provides our plan with a unique flexibility to adapt to the different markets and to overcome unforeseen challenges. So we have overlaid our budget and timeline, and we forecast $780,000 to $905,000 in website app development from researching industry standard pricing. We allocated a significant amount into cybersecurity as we acknowledge the importance of consumer confidence when it comes to sensitive health information. Our next key cost is our marketing budget, where we forecast $755,000 to $1.56 million. And our marketing approach in Shepparton involves targeting the television and print media markets, while expanding to include the use of social media influencers advertising statewide. Our television advertisement production involves the creation of a short 15-second animation following the design of the website in order to establish a brand awareness. And finally, we budget $600,000 into data analysis and research to provide the flexibility that we discussed earlier.
We identified 3 challenges to our proposal. For state and national rollout, our marketing strategy will need to adapt by placing more emphasis on social media and television. Secondly, state and national expansions will cause increased cybersecurity and maintenance costs. To mitigate this, we will budget for upper projected costs. Lastly, we need to collaborate with companies for our health kit promo codes, but we believe our initiative will incentivize companies to collaborate with us. We have further identified 2 limitations. 1, data collection is limited to those who utilize our website and app. By conducting a cohort study, we can compare vaccination rates to previous cohorts to determine effectiveness of our services. Furthermore, a single centralized booking system might be infeasible when our services expand nationwide. So we will aim to provide up-to-date booking details of health clinics and rely on Health Engine where available.
There are 3 clear future applications that our service provides. Firstly, Australia-wide expansion. Our Shepparton flagship project serves as a means to secure more funding for expansion and a chance to evaluate the strengths and weaknesses of our service so that it can be better tailored to community needs. Secondly, our service can be expanded to include other vaccines through our model of online tracking and booking, as well as our digital health pass. Lastly, the potential to link our service to state health databases such as My Health Records will prove to be an invaluable resource to clinicians in providing holistic care. In summary, through our service, we endeavor to provide information, notification, and personalization. Information via centralization of key HPV vaccine information, accessibility to online vaccine booking, and identification of First Nations specific health services. Secondly, notification via our website app mediated appointment reminders in the form of text or email. Lastly, personalization via the digital health passes and targeting the problem of absenteeism empowers individuals to take charge of their own health. That concludes our presentation. Thank you.
Thank you, your cervix. We will now pass over to the judges for question time.
Thanks so much. And what a name. Thanks. Yeah, in your slides were beautifully presented. So I'm Lisa. I just have one question to start, and that would just be, you talked about access to the internet, but I'm just wondering about, this project heavily relies on digital literacy, and just wondering if you'd had any thoughts about that for those that might not be, app savvy or comfortable either having access to the internet and then again using it for this sort of program.
Thanks, Lisa, for that question. So I'm Ava, and I'll just answer this question. So we put a lot of thought into this because we understood that in creating a solution that is online based and requires access to an online platform, we needed to ensure that access to this platform was not compromised. And we knew that with this prompt, we're specifically targeting First Nations adolescents as well. So we were concerned about First Nations individuals accessing our services. So we actually consulted the ALOs at our hospital, and something that they told us was that internet access is actually very commonplace all across Australia, even in remote areas. And we did our own further research, and we found out that in 2014, it was reported that 78% of First Nations individuals had access to reliable internet. Now it's currently 2021, so it's 7 years since then. And we also live in COVID times where, online school is very commonplace. So we believe that internet access is really not a significant problem. However, we also understand that there will be individuals who don't have internet access or are not really literate with technology. So to combat that, what we have done is ensured that our information about our services will be provided to parents during the enrollment process when their child is enrolled into year 7. So when they get things like their book list and all the other information, our services will also be made available. And when that happens, parents are able to use school libraries to access the website, and school teachers can also assist in that process. Furthermore, community centers are very ubiquitous throughout Australia, and they have very good facilities to provide internet access as well. So parents can access community centers, and there will be staff there and other ALOs that can assist in the whole kind of sign up and consent process. So through those methods, we hope to mitigate this issue.
Thank you.
Hi there, it's Tamara here. Amazing presentation, very polished, very streamlined. I was hoping maybe a little bit more out of curiosity, if you could expand a little bit more on your consultation process that you outlined at the beginning. I was very curious to hear about that.
Yes, so I can answer that. So we are all based in Shepparton, and we live very close proximity to Golden Valley Health, which is the local hospital. And so we just one day we went to we found the ALOs, and we just had an impromptu meeting, and I came in correspondence with one of the ALOs, and I essentially in email format submitted our proposal and our ideas, and then she forwarded on to additional community leaders. She was actually very interested in the process and thought it was an interesting idea, and the case study presentation was a very interesting thing for students to be taking part of. So she was really involved in that process, and they were very good for their feedback, and we learned a lot of different things that we thought would be barriers and different things we didn't think would be barriers. And so it was a very good learning experience for us, actually.
Hi, thank you. That was, I agree, a very polished and professional presentation. And I did particularly like the fact that you informed it with some local consultation. That was great. I suppose the question that arose to me was really how your system would interact with existing systems. As you know, we have a huge bureaucracy that develops vaccine systems and sends them up to the Australian Immunization Register. And I suppose my one concern was this seemed to be a little bit standalone and rely on people choosing to use it. And in particular, I guess we very often give the diphtheria, tetanus, pertussis vaccine at the same time as HPV vaccine. And I just wondered if you could elaborate a little bit more on how you think you could get the big health system authorities to really support this. and integrate it with existing platforms. Because I think often we would find resistance that there's often a resistance to change, and any strategies you have about overcoming that sort of resistance to your ideas.
Yeah, thank you for the question, Julia. So my name is Angelina. I'll take this one. So the question, can I just clarify that it's how are we going to incorporate what we currently have with the Australian Immunization Register? And that's actually something our team has really considered deeply, because as we expand Australia-wide, it's going to be very difficult to keep it within our database, because in terms of cost, and if there's already a pre-existing system, it might be worthwhile linking up with them. So I must admit that this is not our area of expertise, and therefore our team have discussed this, and we have decided to consult, like ethics committees. We would also like to consult the infectious diseases specialists and obviously governmental authorities as well, to explore the ethical and political social ramifications of our decision. But as we mentioned in our future directions, there is definitely a potential to link with the Australian Immunization Registry. And in terms of how we're going to communicate this to the public, we have come up with a few reasons as to why it is beneficial to link to the Australian Immunization Registry. So the first reason is for their own health. So individuals can really keep track of their own health status via the Australian Immunization Registry, but at the same time, because the registry is also linked to My Health records and like governmental health databases, it's very easy for clinicians to track their vaccination status and provide holistic care for patients. So that is for the benefit and advantage to our community members. And secondly, justifying the link to the Australian Immunization Registry is for the purposes of epidemiological studies, because I understand from our research that the purpose of the registry is not only to allow individuals to check their vaccination status, but it's also, the purpose is also to conduct epidemiological studies to identify areas that are at risk, and also to calculate like herd immunity rates. So by providing that information, being transparent about it to our committee members, hopefully we'll be able to bridge that gap and convince them to give us their consent to share their data with the Australian government.
Thanks very much.
Okay, so in the last few minutes, as the judges finalize their scores, would anyone in the audience like to ask the team any questions? Please feel free to turn on your mic or send your questions to the chat.
Hi, I had a quick question, and I think that you may have covered this, but I think maybe I just missed it. But how, can you go over just one more time how this would be like rolled out and introduced to like the youth, and how everyone would kind of be encouraged beyond just being provided a QR code? Like how would we ensure that everyone's downloaded it on their phones?
Yeah, that's a great question. Thank you for the question. And I can see multiple stages in this process. So we have the enrollment package being, so the link in the QR code being sent to individual parents during the high school enrollment period. But also we have the marketing campaigns that we're going to be budgeting to run. And so that includes having targeted campaigns, and we budgeted for essentially 15-second slots on Channel 7 at around 5 p.m. So just after school time, that can be targeted towards when individuals first come back in school, to try to have a greater amount of exposure time to our targeted demographic. Additionally, we have also allocated for different social media influencer advertising, so we can target different demographic groups if we want to have our services promoted to different groups in general. But no, great question. Thank you for the question.
Thank you. Good luck.
Thanks for the great presentation at your cervix. I'll wrap it up there, and pass it on to Amy to introduce the next team.
So we're now going to welcome Two Shots to Stop Cervical Cancer and let them present their proposal.
Thanks so much. Just wait till the presenter mode comes on.
Is it not working? Can you see it now?
Yeah, looks good, Amelia. Okay, so thank you. Good evening, everyone. We are Two Shots to Stop Cervical Cancer. My name is Letitia, and I will be presenting alongside Anosha and Amelia. To begin, we would like to acknowledge the traditional owners of the land. For us in Melbourne, these are the Wurundjeri people of the Kulin Nation, but we recognise that you may be tuning in from many places across Australia tonight. We'd like to pay our respects to elders past and present, and any First Nations people that may be with us here today. And before we start, we would also like to acknowledge that it is not yet a given that First Nations people have a say in the public health decisions that pertain to their own health. So we would like to stress that while our presentation will include our strategies to co-design with and empower First Nations people, we are by no means wanting to appear as the actual voice or to be seen as speaking on behalf of First Nations communities in our presentation.
So the main problem we're trying to address is the low rate of HPV vaccine course completion amongst First Nation adolescents. Increasing course completion in First Nation communities is a known health priority. And while there have been some efforts to address this, for example, some research protocols looking at barriers and enablers and education resources directly aimed at these communities, these efforts have not been enough. Our solution is a package of interventions which will be co-designed with First Nations members so that it is culturally safe and effective. We'll also integrate our program with the existing school-based national HPV vaccine program. We will focus our pilot program in regions in Queensland highlighted on the slide. They represent a large group of First Nations peoples, each with diversity in culture and language. They also include metropolitan, regional, and remote areas and reflect the lowest performing regions. With our proposal, we aim to meet the targets set by the World Health Organization to increase HPV course completion rates to 90% for First Nation females by 2030.
A problem tree was constructed to identify the key determinants of the issues. 4 key themes became apparent. In yellow, barriers to accessing services, including inadequate cultural safety, mistrust, and negative experiences. In red, logistical issues, including fragmented reminder and follow-up systems and COVID-19 related disruptions to the school-based vaccination program. In green, lack of knowledge and awareness regarding HPV vaccination and sexual health and stigma about these topics. And finally, issues with inaccurate record keeping of vaccinations. These issues led us to develop a package of interventions to integrate with the existing school-based HPV vaccination program. Firstly, yarning information sessions delivered prior to both the first and second dose. Secondly, take-home packages delivered to students at their first vaccination dose. Thirdly, communication technologies, including automated reminder texts and follow-up calls. Fourthly, First Nations patient navigators to coordinate missed dose appointments. And finally, advocacy efforts with key decision makers. So for the first intervention, for First Nations people, family often extends to a broad collective of extended family, wider kin, and tribal networks. Family and community collective involvement in decision-making has been identified as an enabler in HPV vaccination for adolescents. Yarning information sessions target this collective decision-making process by educating wider families and kin on HPV awareness and knowledge through culturally safe information sharing. Yarning sessions will be promoted via school newsletters, social media platforms, and First Nations organisations. Sessions will be facilitated by Aboriginal healthcare workers, First Nations community leaders, and First Nations advocates, including cervical cancer survivors. For Intervention 2, this next intervention provides packages that will be given to self-identified First Nations adolescents to take home and share with the family. Components include personalised dose schedule cards to remind participants of their second dose, as well as educational resources, which you can see mock-ups of in the slide here. Importantly, these resources will be co-designed with the community, for example, incorporating local artwork, languages, and targeted communication styles. Where possible, we will adapt and link existing informational resources, such as those developed by the Cancer Council. For Intervention 3, communication technologies will allow automated text message reminders in the week prior and the day prior to the second vaccination dose, and will allow tracking of second dose uptake. From there, missed second doses can be identified and followed up via phone calls with our First Nations patient navigators. This leads to the fourth intervention. The role of the First Nations navigators is to coordinate and enable missed dose appointments by helping them book appointments with local health services, including Aboriginal medical services. In addition, the navigators can address any concerns or barriers that arise by linking with other services such as social workers and can follow up missed dose cases with further phone calls to ensure there has been vaccination completion.
The interventions specifically target themes identified from our problem tree. For example, to address inaccurate record keeping, we have information systems to track course completion and link to the communication technologies and immunization register, as well as phone calls from First Nations patient navigators to confirm the vaccination status. I'd like to point out also two overarching strategies in our initiative, sustainability and cultural safety. For sustainability, we have prioritized effective integration, including collaborating with the National Vaccination Program without overlap or detracting of resources, and connecting with local health services and integrating with the vaccination records. The program was also designed for adaptability in the context of the pandemic, such that there can be online delivery of sessions and task shifting of the patient navigators to organise alternative appointments for vaccine delivery should the school-based program be disrupted. Strategies to ensure cultural safety include the delivery of culturally safe information and environments and the communication of knowledge in a way that is meaningful and transparent. And importantly, we aim to recognise not only the systemic discrimination and trauma persisting from colonisation, but also recognise the already incredible achievements of First Nations communities in HPV vaccine coverage. And this strength and resilience of the communities is very important, and thus for both sustainability and cultural safety, we prioritise a high level of community engagement. Expanding more on the rationale for our interventions, the COMBI model is one framework for conceptualizing strategies for behavioral change where capability, opportunity, and motivation interact to generate behavior. And our interventions have aimed to target not only motivation through reminders and education, but also capability and opportunity through addressing access issues. We also identified good effectiveness evidence for our interventions from the results of similar programs. For example, previous programs with automated text reminders and follow-up phone calls demonstrated increased HPV vaccine completion rates in other settings. While cost effectiveness evidence was limited, the findings available in the literature did suggest modest costs are associated with our interventions. Now, to explore how the interventions will lead to their intended impact, we constructed a program logic model, which connects inputs, activities, short-term, medium-term, and long-term outcomes. And I'd like to briefly highlight a few points. Take-home packages, communication technologies, and patient navigators all lead to medium-term outcomes of increased vaccine service uptake in both the school program and catch-up appointments. Yarning information sessions lead to medium-term outcomes of increased knowledge, decreased stigma, and increased acceptability. And this in turn will hopefully also increase vaccine service uptake. And in this way, our program activities start to reinforce each other. Through advocacy with key decision makers, we hope to see policy changes that support funding for the program and that promote accurate record keeping, such as the strategies that have been implemented in New South Wales that provide cultural safety training for school vaccination nurses and empower the school vaccination nurses to check First Nation status. And we hope the program will then be accepted as a standard approach, leading in the long term to increase adoption of our interventions, which importantly sets up a positive feedback loop to reinforce all the other program activities.
So in terms of our timeline, we will deliver the project over a span of 3 years in specific focus regions. The first year is represented here on the Gantt chart. In the first 4 to 6 months, we will have our initiation phase. This will include consultation and co-design with stakeholders, recruitment and training of staff, development of the program content, and development of communication technologies. Once this is done, we will roll out our interventions in line with the current school-based vaccine schedule. This will also be accompanied with continuous monitoring and evaluation to adapt our program. Based on the success of our pilot program, we hope that these interventions can then be rolled out to a state and national level.
For our budget over 3 years, we considered cost categories of human resources, equipment and facilities, consumables, evaluation, overheads, and have also accounted for contingency costs. The two key cost drivers were salaries and development of communication technology and information system software. We have also accounted for financial reimbursement of community members and other stakeholders for their participation during the consultation and co-design process. And we expect our final cost to be just under $3 million.
We want to also formally analyse the implementation and outcome effects to make sure that we are meeting our objectives. In order to do this, we will collect data throughout the project and perform a quarterly analysis. The findings from these evaluations will then be shared with key stakeholders, including First Nation communities. We'd then like to use these evaluation reports to determine any changes we need to make to our program. So an example of an implementation evaluation seen in the table here is assessing participation within the program activities. And we'll do this by looking at the number of participants in our yarning sessions and the number of families consenting to communication. We also conducted an analysis to explore stakeholder concerns. Here we have a table of the key stakeholders and potential engagement strategies. The National HPV Vaccine Program was identified as one of the highest priority stakeholders with high power and high interest. The possible concern could be the ability of our program to effectively integrate with the existing program. Our engagement strategy in this case would be to collaborate extensively and communicate our goals. We also want to highlight here, there may be some concerns from Aboriginal healthcare workers that our program may increase their caseload burden. To address this, we will ensure that there is adequate consultation and good opportunity for feedback. And finally, we have identified certain assumptions and potential limitations inherent to our program initiative. Some of these include participant access to technology, presence of school and community infrastructure, self-identification of First Nation status, the translatability of evidence, and the willingness of stakeholders to collaborate. In light of this, we performed a risk assessment which is shown in the table below and considered ways to mitigate the problems. An example I want to highlight here is the inadequate infrastructure at schools and communities, where a potential strategy would be to liaise early with schools and work together to develop solutions. That is the end of our presentation. Thank you for listening. We're happy to take questions.
Oh my gosh, that was so deadly. Well done. Incredible work. Very well packaged and integrated. So I think I have two questions. So I want to know a little bit more about the patient navigators. So I want to understand, maybe you've covered it, but where do they sit? Are they at the school, health service? How do you see them relating to the community and their role there?
Yeah, so I guess beginning quickly on that, where we came with the idea of the patient navigators is that we know that it's done a lot in First Nation communities with chronic conditions. And while I don't believe it's happening for HPV vaccination or vaccination in general, we did see evidence of programs overseas where patient navigators had been effective at increasing HPV vaccine completion in clinics for HPV vaccines. So our navigators won't be directly based with certain clinics or directly associated with certain schools, but will rather act as the gateway between schools and clinics. And so they will connect with the schools that are involved in our program, and that's how they will engage with students through the schools involved, but then will connect into all the clinics and Aboriginal medical services and GPs that are existing within our program. So that's kind of our rationale, is that they're this gateway, this bridge for catch-up services.
Yeah, lovely. Okay, and if I can be so daring and ask a second question. So I think you've tackled a good problem of addressing that that second dose, but I guess I'm wondering about sustainability. So how are we going to make sure that that first dose still remains high? Because it seems like the intervention you've designed seems to hinge on making sure you get enough people for that first dose so you can start to roll out the other steps.
I guess inherent in our program, we have our information sessions early on in the school year, where we make sure that we engage community members, First Nation community members, and actually have shared learning where we also, I guess, promote the vaccines, HPV vaccine uptake, as well as course completion. So we'll introduce the importance of HPV vaccine course completion and the whole schedules there, and also have avenues for discussions about why it's important, and even in sexual health as well, sexual health education, and other important aspects of HPV prevention.
Lovely, great, thank you.
I'm going to ask just a quick question, which is really a follow-up to one of Tamara's around the navigator role, which is really interesting. And thank you very much for your presentation. I've thought a lot about navigators for other work, actually, but I have to say I haven't thought about navigators for this. So you've got me on that. Can you, and I'm sorry if I have missed that, can you talk about whether the navigator you think can play a role in that first dose? Just in terms of the information session you've just talked about, it seemed like they were just for the second dose, but if you can clarify.
Yeah, definitely. I think when we sat down to try and problem solve our problem, we were very much focused on a second dose, but it definitely can be expanded to target this first dose as well. And one of the things that we have actually discussed together and considered about this is the entryway into our program in some way involves students and families signing up when they consent to the first dose through school. And we were thinking about, you know, what happens if students don't consent to this program through that, or they're not in school, or the logistical issues with consenting through school through that first dose. So we decided that we would want to connect patient navigators to patients also through the yarning information sessions before they've even had their first dose. And through the connected healthcare providers that are part of our that are connected to our program and the Aboriginal Medical Services, if we can identify students that might not sign up for the program through those healthcare practitioners, they can identify those students and link them to our patient navigators, then that also targets them before they've even had their first dose. So it's definitely an area that we would need to build upon and kind of knuckle down on the fine details. But we have started to think about how we might interact with people before they've even had that first dose with these navigators. Yeah.
Great, thank you.
Thanks. I also thought it was a wonderful presentation, and to be honest, there was so much in there that it's I'm kind of a little bit speechless in terms of pinning down an exact question that I'd like to ask you. I also did, you know, I think the patient navigation thing is really interesting, and I guess my issue would be that perhaps people would say it's not going to be very cost effective to have a patient navigator for potentially a small number of students who haven't had their dose and so forth. So I did wonder whether you thought that perhaps that role might be something that would also have other potentially related roles in the community, and whether that person might already have an existing role in the health sector and could multitask, and that perhaps that would be a really great way of getting other stakeholders involved in the program if you can provide some funding and support to this person who perhaps is part-time in this role and then also connects with families in other ways. So I just wondered if you'd thought about the sort of cost effectiveness side of funding patient navigators in, you know, an already stretched healthcare system.
Yeah, absolutely. Really great question, and definitely really important things about how the patient navigator can exist in the community and in the wider healthcare system. In terms of the cost effectiveness of it, we did try and do a literature search into cost effectiveness data and found very little on patient navigators. And we were talking about this and how we would justify the cost and especially within our budget. And although the issues with vaccination are really complex, and sometimes there can be a lot of complex social barriers that might be involved, HPV vaccination isn't a chronic condition that requires a large amount of dedicated time from the navigators. So we believe that we could get quite a large volume with a few navigators, but it's really important that we don't just take a patient navigator just for a little bit of time and do a job that can't sustain them. That's like something that we really wanted to acknowledge. We wanted to make sure that it was we were properly supporting, because hopefully this is a community member, a First Nations community member is what we hoped. We want to make sure that we're not disadvantaging them in any way by giving them a difficult job to task. We did discuss how they could be involved in task shifting in the COVID-19 pandemic, in arranging navigation and appointments through that. And we also discussed future rollout potentials if these navigators could, because they'll be so linked in with HPV screening and cervical cancer advocates, if they can play a role in cervical screening navigation.
I'd also want to add to, during the evaluation process as well, we want to make sure that we're engaging with the First Nation patient navigators and listening to their concerns and having that feedback communication open, so that we are considering when things are getting too much or when things need to be modified, so we can implement changes throughout our program initiative.
So as the judges just finalize their scores, is there any further questions that anyone would like to add? So just in the chat, Sarah is saying, great presentation, guys. For intervention 2, how would your information brochures be culturally appropriate and different to those already provided by current state health departments?
Yeah, so for the second intervention, we talked a bit about, making sure that we're using targeted communication styles and also using local artworks. I think that's really important. And obviously getting in different people involved with how we're going to communicate, because communication is obviously different with other groups than with First Nations, and it's going to depend on a lot of factors, including location, levels of literacy, like cultural considerations and English proficiency, and of course, access to technology. So, it's also understanding that when we're there, there's going to be barriers to engagement because of past experiences, and hopefully with this co-designing that we're going to have, it's going to help make these different and more actually personalized to that groups. Like the main goal is to be respectful and culturally safe for these.
And just building on what Amelia said as well, is that we don't want to overlap what's already been done. So we are planning to link in some of the brochures that exist, like we mentioned the Cancer Council brochures, but we just want to make sure we're also adding very targeted, as Amelia said, very targeted to the local community, designed by the local community. So it feels very much like we're encouraging everyone in the community to be involved in this program to help stop cervical cancer together as a community.
Well, thank you again to your team. That was really great. And unfortunately, that's all the time we have for questions.
Great. So let's now welcome to the floor the chronic overcommitters.
Hi guys, so good evening. Before we begin, we'd like to acknowledge the Bidjigal and Gadigal people who traditionally occupied the Sydney coast, and we pay respect to all Aboriginal and Torres Strait Islanders elders past, present and emerging. No woman should be diagnosed with cervical cancer. Today, we would like to propose a multi-pronged approach to solving the pertinent issue of poor HPV vaccination completion rates amongst First Nation adolescents. In providing our proposal, we will discuss the issue diagnostic, provide a detailed roadmap including financial modelling, and lastly discuss the overall impact on key stakeholders. We have identified 3 core issues that contribute to lower HPV vaccination completion in First Nation adolescents. Firstly, low health literacy, as 95% of First Nation people struggle to understand common health terms. Secondly, lack of awareness amongst providers, with 67% of GPs being unaware that vaccination coverage is poorer for First Nation people. And lastly, a lack of access to vaccination, with 24% less likelihood of First Nation students attending during the school year, meaning that their access to the school-administered program is diminished.
While existing programs have made significant progress towards the World Health Organization 2030 target of 90% coverage, further interventions are required to catalyse a 35% increase in coverage to attain this goal in 9 years. Our proposed initiatives explore the existing gaps in the current model and aim to address them in 3 stages. First, short-term lowering of barriers. 2, long-term increasing of education amongst First Nation people. And 3, an innovation and ongoing vaccine research. To increase vaccine uptake, we need an adjunct to the current school-administered program. Pharmacies have been historically underutilised in vaccine administration and can help to solve the administration challenges faced by the current school model. Approximately 65% of Australia's Indigenous population live in regional and remote areas. It has been shown that in 566 towns in these high First Nation population regions have at least one pharmacy that could be utilised to administer the vaccine. Rural pharmacists also play a more significant counselling role, having greater influence on the health choices of the community. The feasibility of pharmacy-administered vaccines has also been proven in the current COVID-19 situation, with 3,209 pharmacies across Australia currently administering the vaccine. The current pandemic has also led to the reinstatement of community-led health initiatives from government-led programs for COVID-19 vaccine administration. The reinstatement of the Malala Community Health Program in Maningrida led to the COVID-19 vaccination of 50% of the Maningrida population in just 4 days. This higher uptake was attributed to seeing traditional owners and elders reaching out to residents in traditional languages about the vaccine, highlighting the efficacy of this approach. We propose investing into First Nation community-led programs in Queensland to drive similar improvements in HPV vaccine uptake.
Healthcare data has never been more accessible than today. The Australian Immunization Register contains records of First Nations people, among other Australians, that live in rural areas and that have not received the second dose of the HPV vaccine. By investing in culturally sensitive text messaging that alerts them of the availability of the vaccine in local pharmacies, we hope to drive uptake of the newly available service. In the longer term, our proposal will advocate for the monitoring of the AIR records for vaccine uptake, as well as course completion, to determine if our investment in specific initiatives in Queensland has yielded a desired effect and closed the gap. Based on this, we can determine the investment needed to drive similar uptake in other states if successful results are achieved. First Nations people face prejudice and poor treatment within the healthcare system that has led to widespread mistrust of medical professionals and subsequent avoidance of care, such as vaccinations. Though First Nations training exists for registered doctors and nurses, no initiative exists to involve First Nations elders in health planning. This is insufficient to meet the needs of rural communities. Involving First Nations elders in the healthcare planning of their communities will increase return participation in HPV vaccinations and is proven to improve positive health outcomes. Under our initiative, 300 First Nations elders in MM6 and MM7 regions of Queensland will be sponsored to complete accreditation, specifically the Certificate 3 in Aboriginal and/or Torres Strait Islander primary healthcare. This will allow them to provide primary healthcare, including HPV vaccinations, to their own communities. Additionally, it will provide elders with the skills to identify community health issues, needs, and strategies, as well as providing health screening, promotion, and education services, including medicine delivery. It will also facilitate culturally sensitive and relevant primary care being provided to the most vulnerable people within our society.
A single dose vaccine schedule could not only eliminate the need for multi-dose completion, but potentially create landmark improvements in medicine delivery across the field. By implementing a one-dose vaccine, we would immediately achieve greater than 80% coverage amongst First Nation adolescents based on current first dose uptake. The current Gardasil vaccine schedule requires high administrative and logistical costs, cold chain supply requirements, and prolonged vaccination schedules. Accordingly, innovating vaccine platforms and delivery devices to break that cold chain limitation and mitigating the aforementioned barriers would be an excellent solution. An ideal single-dose vaccine needs to be biochemically stable without the need for cold chain logistics and utilize a vaccine delivery device to facilitate self-administration in resource-poor First Nation communities. A recent preclinical study by Shao et al. Demonstrated the feasibility of a melt processing method to encapsulate virus-like particles into biodegradable polymers to be implanted. When implanted subcutaneously, intact virus-like particles were released slowly over time, and the resulting antibody titers was similar to that of traditional schedules, providing confidence that the implants could be used as a single-dose vaccine platform. We propose funding an accelerated model phase 1 clinical trial to explore safety and immunogenicity in humans in collaboration with partner institutes such as the Walter and Eliza Hall Institute, Peter Mac, and the Olivia Newton-John Cancer Research Institute. An accelerated model of vaccine development, as showcased through the COVID-19 pandemic, can catalyse rapid development of a single-dose HPV vaccine candidate, whilst maintaining ICH safety and efficacy standards. More so, the design concepts discussed here are highly adaptable and would be applicable to any infectious disease. The concepts described are especially appealing because they are scalable and fit within the traditional workflow of pharmaceutical production. Likewise, the device platform is common within the pharmaceutical industry, where hot melt extrusion is a common method to make pills and devices.
Our multifarious approach necessitated careful allocation of funding with a needs-based lens. Investment in some initiatives, as you can see, is concentrated in Queensland. This is our short-term launchpad for this multifaceted program. Our initiatives are looking to solve endemic issues, so I anticipate that a 5-year timeline for most activities will be most sensible to see the effect on vaccination completions. We have allocated the bulk of the funding to the following initiatives. Firstly, direct investment of $1 million into community-led program in Queensland and $900,000 allocation for a subsidy of Certificate 3 training for First Nations leaders in Queensland communities. Both are due to start at project commencement in 2022. We have also prioritized allocating $1 million into vaccine research by utilizing strategic partnerships and existing infrastructure of our collaborators. Our estimations of pharmacy-led administration and SMS reminders by the Australian Immunization Registry have been costed conservatively at $100,000. We have outlined the financial considerations. Now let's look at the project risks. Our comprehensive risk analysis of the overall project indicates no apparent high probability and impact risks. For all the low to medium risks, we have developed clear and easy to implement mitigation strategies. For example, considering the ongoing disruption of COVID-19 to the administration of healthcare, education, and research, we suggest that scenario planning is implemented to prepare for maximum delays and remote operation of incentives is enabled where possible. We're confident that this project is feasible. Now we would like to outline its potential impact. To close the gap in course completion, we need to tackle this issue from a number of angles. Our proposal finances many of the stakeholders that are involved in education, care delivery, and fundamental research that creates and delivers healthcare successfully to our communities. Importantly, we are externalizing the delivery of this program to the groups that are already best placed to make this impact. They just need the funding. Our impact is simple. We reduce barriers to vaccination by improving the delivery of the vaccines. We also invest in education and research to create an awareness shift and deliver better vaccines for our most vulnerable and for all. By synchronizing our proposed initiatives, as we have described, we compound this impact. Let's end HPV for all, and importantly, for our most vulnerable. Thank you.
Great. Thank you, team, for your presentation. Now let's pass over to the judges.
I was waiting. I thought someone else might go first. Sorry. Thanks so much for your presentation. I love the title, the chronic overcommitted. I can relate to that one. Thanks very much. Sorry, can I just go back to the pharmacy-led and how that kind of, if you could just clarify for me how that integrates and supports the school-based immunisation program?
So we would use it kind of administering it, I guess, slowly phasing it into the program. Obviously, we can't get rid of the school program immediately, and obviously you have to test on a small scale before we could implement a purely community-based program. But the aim would be to kind of reinstate more, I guess, community-led programs in those local communities, as well as through the pharmacies, so that anyone who might miss the school program could go to their pharmacy to get the vaccine, because we know that a lot of the times those school programs are only run across a couple of days, and that means that if they haven't received their I guess approval from their parents to get the vaccine, or they've missed that school day, or they were sick over those 3 days, they don't have the opportunity to get that second one done. And so by being able to go to their local pharmacist who they know has got the approval to administer that vaccine, I guess gives that, the safety blanket if they miss the school program to go to that pharmacy and say, can I get my second dose done?
Great, thank you.
Just to add to that, Lisa, if that's all right, when we looked at this, we sort of thought about it from the lens of, how do we make sure that there's more access to these vaccines for the Indigenous population. And we looked at, what if we invest more into the school program, or we reformat it so that it's more accommodating for the Indigenous population. And we realized that perhaps actually supplementing it with the pharmacy-led administration, they're more than capable to do it. And so if we can enable them to do it, and we incentivize and bring the missing pieces, the communities, to talk about, the structure of it, and incentivize and bring that awareness, then we can create a reason resource that doesn't depend on school attendance rates, doesn't depend on where people live, and gives a bit more of that flexibility to the community.
Yeah, no, thank you. Thank you very much. Really excellent and great to see those learnings from COVID coming through in this presentation.
I might just jump in there because I did like your sort of a little bit out of the box thinking about pharmacy-led vaccination. I guess around the world, the out-of-school kids is very challenging for all HPV vaccine programs, working out how to reach them, and often they're not really well connected into primary healthcare services either. So in fact, pharmacy is quite an interesting idea as a model, particularly I guess in areas where there is a shortage of other health services. I suppose my first question was, what do you think about the politics of that? You may be aware that there's quite a bit of resistance amongst the medical community to shifting vaccination into pharmacies. How do you think you might overcome that sort of resistance?
I might tackle that one. I know that there's definitely some contention between the College of Royal Australian GPs and the Pharmacy Association in terms of who should be administering vaccines. But I think if the COVID-19 pandemic has shown us anything, it's that when there is a significant health issue like HPV vaccination at play, those collegial groups can work together to determine what vaccines are better placed to be perhaps delivered at the pharmacy. For example, the flu vaccine is now more commonly delivered at a pharmacy, given it's more accessible sometimes. And I think the College of Royal Australian GPs, by outlining to them that you've got a resource poor community with an overburdened primary care physician who is hard to get into, or you've got nurses at these practices who are overworked and can't even deliver vaccines on a normal schedule. By supplementing that with a pharmacy-led approach and by actually increasing the uptake, it's beneficial for that major public health issue. So I guess the approach there would be to outline, I guess, the severity of the endemic issue, and then provide, I guess, a statistical and a sort of resource acknowledging proposal.
Yeah, that's great. And I guess, that we are leveraging COVID in a way, because it means all our pharmacy-based vaccination will now actually go into the Australian Immunisation Register and all of those systems. It means that all those healthcare providers can work together rather than being in a silo of not knowing if they've received a vaccine somewhere else. So that's great. I had one more question, which was just, I like your idea of using the Australian Immunisation Register more actively and getting them to actually proactively communicate with people if they've missed a vaccine dose. I guess I just had a technical question. Are we sure that the AIR has people's mobile numbers in it? I know school-based consent forms certainly collect that off parents, but I don't know if it actually populates up to the Australian Immunisation Register. So I just wondered if you'd checked whether they do actually have that field to make your proposal feasible.
Yeah, I did look into this, and I believe that it did have mobile numbers, but it could also be, we could sort of tweak it and have it, linked to emails as well if that was a blocker, or we could potentially think something. It definitely would be more effective as a text messaging service, of course, and I believe that it does have it, but I may be wrong. So that's something that we would definitely look into further.
Thanks very much. Over to you, Tamara.
Thanks. Another great presentation, well done, and just so multi-pronged, like covering lots of bases here. I loved that you had put in a significant investment into the workforce. I think it's a really nice aspect of your proposal. But the great thing about that certificate is that people can do, whatever they want with that. They can go off and specialize in anything they like. So I'm just wondering how you'll sort of, I don't know, if you had any thoughts around, do you intend that to sort of those certificates and training and things to go towards, HPV vaccination or cervical cancer prevention, or, is that just more a general sort of like lifting of community-led engagement in health sort of approach?
Yeah, so from the case studies that we were looking at with the communities and passing over to First Nations community leaders for the COVID vaccination programs, we found that health leaders really were invested in achieving particular goals. So the idea would be to sponsor the completion of these programs initially for the implementation of HPV vaccines. But as you said, because they are so multifaceted, what we found was this qualification qualifies workers for the Workplace Incentives Program, which provides support payments on an annual basis for continued support of Indigenous communities and for the startup of Indigenous health practices, particularly in regional areas. So by providing a qualification that specifically meets the requirements of this existing federal program, we're hoping to incentivize a continued kind of community effort across all facets of health, really.
Just to add on to that as well, but I think we were driven to really consider this as a major investment and proposal because of those striking statistics around how some of the primary healthcare providers that are in those areas are not actually as exposed and as aware and haven't received the training as such to administer the right care to First Nations people. And so it's on the basis of, getting more people that are aware of those issues to actually be able to administer that care is important for so many reasons.
Thanks.
Great. Really awesome presentation and questions. Thanks, everyone. So I think we're now going to have a quick intermission before our next presentation. Thanks to all the 3 teams who have presented already, and we'll kickstart the final 2 teams after 5 minutes.
We hope everyone had a nice break. Let's now welcome our next team, Catechist Consulting, to present their proposals.
Okay, good evening, everyone. We are Catechist Consulting, a team committed to finding solutions that help create a brighter, happier, and healthier world. We are extremely excited to share our strategic approach to improve the HPV vaccine course completion amongst Aboriginal and Torres Strait Islanders. Before we begin, I'd like to acknowledge the traditional custodians of the country throughout Australia and their connections to the land, sea, and community. We pay our respect to their elders, past, present, and emerging, and extend that respect to any Aboriginal and Torres Strait Islander people here today. So, from the case file, we're told the story of a young First Nations woman who has tragically developed cervical cancer. For the purpose of this scenario, we've named her Melissa. Whilst Melissa's story is fictional, the scenario still holds true, particularly for First Nation women. We at Catechist Consulting have identified 4 key problems which may contribute to these lower rates of course completion. Number 1 is unclear information. With any vaccine, there may be skepticism and unclarity. That's why education about the HPV vaccine, particularly the importance of completing the full course, is vital. Secondly, school absenteeism. The HPV vaccine is largely administered through schools, and with a high rate of Indigenous children absent from school, this presents another barrier. Thirdly, the lack of culturally appropriate care. With any form of healthcare, it's important to be culturally sensitive and aware, particularly with Aboriginal and Torres Strait Islanders who've experienced generations of mistrust in the healthcare system. And lastly, accountability. A lack of accountability can occur due to the lack of reminders of an upcoming second dose. Additionally, communication difficulties due to the increased First Nations population mobility presents another challenge. It's clear that there are stark differences between the health of Aboriginal and Torres Strait Islanders when compared to the non-Indigenous Australian population. Aboriginal and Torres Strait Islanders face a 3 times greater mortality rate when experiencing cervical cancer. And unfortunately, the rate of cervical cancer is nearly 3 times higher amongst First Nations. The major source of primary prevention for this disease is the vaccine, but socioeconomic differences, coupled with disparities between rural and urban vaccine coverage exist, which exacerbate these health inequalities, and these may contribute to First Nations having a markedly lower HPV course completion, with a difference of more than 10%.
So, how will we reach our target of 90% vaccination course completion? First, we would like to outline the framework that we established this proposition on. The fabric of well-being sets out integral aspects of Indigenous health that largely influenced the tailoring of our strategy to Aboriginal and Torres Strait Islander peoples, considering culture, community, and family. Now, with that said, allow us to introduce Strategies Connect, our three-pronged approach designed in response to the multifaceted nature of the issue, which has been previously described. Firstly, Schools Connect involves the implementation of school-run health days at the time of HPV vaccination, which will engage students through interactive cultural immersion. Sponsors Connect enhances motivation to acquire the second HPV dose through a sponsorship program for high-priority schools. And finally, Supervisors Connect is aimed toward parents or guardians through an HPV vaccination tab on the Medicare app and website. First, let's talk more about Schools Connect, which intends to maximize course completion through specific health days within each school by upgrading pre-existing vaccination programs. This targets school absenteeism by generating anticipation for what will be a memorable day for students receiving the vaccine. A guidance document will be provided to help schools plan for this key calendar date. Schools Connect will also address the lack of culturally appropriate care by raising awareness of the First Nations cultures, drawing from the fabric of well-being. Now, we acknowledge that not all schools will be financially able to conduct the various aspects of the strategy. Therefore, priority schools will receive subsidization funding. And as before mentioned, enhancing an already established system minimizes costs, such that a greater emphasis can be made to support Aboriginal and Torres Strait Islander students. Currently, school programs run to solely vaccinate students. However, we see this as an opportunity to also educate them about rationale and the importance of immunization. This further motivates students to obtain both HPV vaccination doses, coupled with our other aims of improving understanding of the First Peoples and general sexual health. And to aid with all this, schools across Australia will be provided with a document to outline the purpose of Schools Connect, as well as the proposed activities to run on health days, which includes smoking ceremonies and Dreamtime story sharing, among several others.
Our second strategy focuses on priority schools with low HPV course completion rates amongst its First Nation students, which will be identified by 3 eligibility criteria: the difference in First Nation students' vaccination course compared to the same age non-Indigenous students within a school grade, the population of First Nations peoples within a school catchment area, and socioeconomic status. The top 100 eligible schools can enroll in our Sponsors Connect program, and this introduces an incentive which engages students and schools alike, improving motivation, accountability, and fostering a sense of community. If 95% of their cohort completes their HPV vaccination course, schools will be able to earn vouchers for resources which benefit their student population. Ultimately, the strategy will foster a collective desire to complete vaccination. This initiative is largely self-funded. Vouchers will be acquired through connecting with youth and school-friendly sponsors, and a new sponsor will fund Sponsors Connect every year. Our strategy's efficacy is backed by rising corporate social responsibility, which typically constitutes 1.5 to 1.8% of a company's annual profits. Sponsors will be attracted with the opportunity to increase brand exposure and establish a relationship with local communities. An in-kind sponsorship program may also increase involvement due to increased flexibility and independence with allocating resources. Undeniably, sponsors will also be engaged by outlining the impact of their contribution on First Nations peoples, Australian children, and national health. Family is a central value amongst First Nation peoples. Thus, our third and final strategy is to extend HPV education and follow-up to the home. A second dose is commonly missed simply because of a parent forgetting to ensure their child's vaccination, only heightened by the 6-month gap between doses. Our solution? Supervisors Connect introduces a HPV-specific page to the pre-existing Medicare app and website. This page will include a date tracker, which outlines the dates of an individual's vaccination and creates awareness of the 2-dose schedule. It will also have push notifications sent close to vaccination dates to ensure a second vaccine is not forgotten. Lastly, it will work perfectly with Sponsors Connect and Schools Connect by displaying the vouchers a school has earned thus far in order to increase motivation to attend school and receive the second dose. Our phones are always on us. This solution is simple, but thereby sustainable and effective.
Now let's take a look at how different things would be for Melissa if Strategies Connect was implemented at Kinroy High. Her school's fun, interactive health day would mean she was excited to attend school on vaccination days and would learn about her health and culture. The Sponsors Connect voucher program would motivate Melissa and her friends to complete their vaccination courses in order to win prizes for their school. Melissa's carers would also be reminded and informed about the importance of the HPV vaccination. Thus, Melissa would have completed her full course of vaccines and hence been protected against 90% of cervical cancers. Implementation of Strategies Connect will begin with contacting First Nations elders and local health committees who will be at the forefront of every initiative at every stage, with regular training days for those involved. This will be followed by resource and app development while reaching out to sponsors, with First Nations communities and school leaders involved in nominating sponsors. The biannual vaccination days will be implemented from year 2, while the efficacy of the program will be assessed regularly and adjustments made accordingly. Now, the involvement of schools, sponsors, and technology raises several issues that must be addressed for the solution to be viable. We present here a risk matrix comparing incident probability to impact. A primary issue is the abundance of schools and the lack of adequate resources and finances, which will be mitigated by focusing on priority schools and encouraging community fundraising events. Lack of access to technology may also create limitations in the use of app and website. However, this does not present a significant problem as this solution is supplementary to schools and Sponsors Connect. The student and carer will therefore be well informed of the vaccine by their school and community leaders. Partnering with sponsors also presents a risk of insufficient contribution or dropping out. This risk is mitigated by creating strong relationships with regular sponsors and allocating excess budget to the prize pool. So, to wrap it all up, in order to increase the HPV course completion rates amongst First Nations peoples, we must address the key multifaceted foundational issues. Catechist Consulting thus proposes a three-pronged approach, which lies below the $3 million budget, targeting schools, students, and supervisors with the help of First Nations communities and elders to enhance the efficacy of current school-based vaccination programs, and thus increase course completion, leading to better health outcomes. Thank you.
Thank you, team. We'll now pass over to the judges for question time.
I should probably go first this time. Another wonderful presentation and some lovely ideas in there as well. I love the naming and the connection. I think that's fantastic. I suppose my first question was your central part about Sponsors Connect. Did you find much evidence in the literature that sort of, I guess, group-based reward actually does change behaviour, and any research into school HPV vaccine programs that might have tried that sort of incentive approach? And if you did, what did you find?
I can take this question. So we did quite a bit of research into how incentive plans actually work, especially with school-aged children. It's been shown to be really effective as they can have this idea of not only coming together as a group, but also being able to achieve and receive rewards that they can see throughout the following years. A good example of this is how Coles has run their sorry, I forgot the name of it, but they have a program in which you get the stickers and you can then exchange it for vouchers. And that has worked really well. And we noticed even like when we used to go to school, we were really excited to go and shop at Coles and Woolworths to get those stickers and to be then rewarded with the resources for our schools.
Do you think there's any ethical dimension there? Did you want to comment on, do you think the community could have some concerns about using rewards to improve vaccination rates? Just wondering if you'd engage with that as an issue.
Yeah, so we definitely considered that while we were coming up with the strategy. And the reason why we went ahead with implementing the strategy of this incentive-based approach is because the literature clearly shows that amongst Aboriginal and Torres Strait Islander peoples, the problem isn't that they don't want to be vaccinated, it's more so that they are forgetting to complete the second dose. So even though it is an incentive, because the primary problem isn't that they're not wanting to get the vaccine, it's simply incentivizing them to complete the course that they already wanted to complete, but simply either forgot or didn't realize they needed to.
And to add on to that, if I'm able to, Yeah, while we were thinking about the incentivizing strategy, we decided that this approach would be the best, as we aren't directly sort of incentivizing individual students based on who gets vaccinated, and like if you are part of a school that has more Aboriginal or Torres Strait Islander peoples, but in the way that we are able to give the sponsorship vouchers to schools, it broadens out the ethical dilemma in that it's not like an individual thing, but more of a community-based thing.
Thank you.
Thanks, team. That was another really interesting presentation. And again, you're tackling lots of different aspects, so I think that's really good. So I love that you'd had a look at the fabric of wellbeing work and incorporated that. I was just hoping you could expand a little bit more on how you see that playing out on the sort of the Schools Connect part of your strategy, and how that model kind of works within that context.
Yep. So the Schools Connect part of the strategy, our main aim for that, which we drew from the fabric of wellbeing, was taking the culture aspect of that. And so like we were showing before in the guidance document and such, we've integrated a lot of Aboriginal and Torres Strait Islander activities into the day, so that there's a big emphasis on that, because we sort of want to cultivate this idea that health is something that is for everyone, and that health is something that is very much achievable and a right for our Aboriginal and Torres Strait Islander peoples in Australia as well. And so creating a day where we can emphasize both aspects of that is something that we have put in. And of course, our priority when creating all of this would be to engage Aboriginal and Torres Strait Islander representatives in order to have a voice in implementing all of these strategies, and making sure that they see that this would be fit for schools around Australia as well.
Just to add on to that as well, another big part of the fabric of wellbeing, which ties into the family, community and culture, is this idea of holistic health. And that's something that we're continuing to emphasize throughout this day, that just emphasizing how the vaccine actually plays into the idea of holistic health. And each of the activities that will be running on these days and that will be specified in this guide document for the schools to run will be emphasizing, will be emphasizing the idea of holistic health.
Great, thank you.
Thank you. I'm just wanting to know a little bit more about who is delivering this. So, and I love that idea of Schools Connect, and you'd be giving this manual, but I'm just thinking about who you're envisaging would deliver this, and whether there'd be capacity, I guess thinking about feasibility within the school system to actually deliver this. And then I guess just a follow-up question to think about, if schools do prioritise this, or whether they feel that school immunisation sort of is something that just kind of comes in and gets delivered and they're not really part of it. So wanting to know whether this kind of is aiming to address that as well. So two questions there, the who for feasibility, and then if it will address that barrier.
So in terms of the who, we do really want to get schools like really involved, and have like school staff that are very much on top of running these days for the schools. Like we mentioned here, we have, or maybe here, we have, or maybe not, but anyway, we have training days for people who are involved in our strategies. So this is particularly, well, not particularly, but for elders, as in, First Nations elders, so that they can get really involved with the schools that are within their community, but also for the staff of different schools who want to be trained to culturally appropriately deliver these different activities. And we have allocated room in our budget for doing so as well. Sorry, what was the other part of the question?
Just thinking about how schools, whether they feel part of the vaccine program or not, and whether that's sort of manual will help to sort of bridge that gap, I suppose, between immunisation staff just coming in and vaccinating kids And, you know, because sometimes there's a bit of a disjoint there.
Yeah. Yeah, well, I believe just having a day that the students and the staff at the school look forward to as a whole, like health day, which is why we wanted to name it like a health day, and schools can take that as they will. But yeah, that we integrate, this idea of holistic health throughout the entire day, and that vaccination is just a part of it, which is helping to obviously to increase the course completion. But as a part of that, we have to focus on whole health.
Thank you.
Just as the judges finalize their scores, I can see there's a question in the chat. Given that schools are already overburdened, do you think that they would have the capacity to administrate this program?
I can take this question. So with the overburdened aspect of the question and the capacity to administrate this program, ideally this would be a program that would be pretty easy to run, and we're leaving a lot of exactly what the school wants to do up to the school and what the capacity of the school has to do. And ideally it would be run in conjunction with the prefects and the SRC of the school, as well as potentially parent volunteers. So the school wouldn't have to just do it all by themselves, like not just the teachers. So by having these extra supports, as well as for our top 100 priority schools, that $600 budget that we've allocated for each of those top 100 priority schools to help them be able to incorporate this into part of their school program.
Thank you very much for that. I think if there are no further questions that's coming up in the chat or anyone on mute, we are happy to move on to the next group.
Now, last but not least, let us welcome HIT, HPV Indigenous Immunization Task Force, to present their proposal.
All right, just going to share my screen. Can everybody see that?
Yep.
That's good, Beth.
All right, great.
Okay, so HPV vaccination has achieved great coverage since its incorporation into Australia's National Immunisation Program. But whilst the country is on track on a population-wide scale, there is a glaring disparity that still makes us question why. Why are Australian Indigenous women dying from cervical cancer at 4 times the rate of other women? Now that is the $3 million question. Well, to answer that, we need to first understand the barriers within the HPV vaccination program. Firstly, the HPV vaccination course completion rate is about 12.7% lower for Indigenous Australians. And on top of that, Indigenous Australians on average take a longer time to complete the HPV vaccination course. And to cap it off, we have been terrible at measuring Indigenous people's vaccination rates. And all of these have a real silencing effect that hinders any implementation of strategies. And now I know that sounds like a lot to take in, but let me tell you why these major barriers exist. Firstly, there are intrinsic factors like a person's awareness, perceptions, and attitudes. Secondly, there are some situational factors like a person's environment or their experience. Lastly, there are some structural factors like students not returning consent forms, being absent from school, and not having access to culturally safe support services. Now, let's have a look at the current vaccine rollout plan and see where things can be improved. Currently, the rollout involves multiple back and forth communication between the school and the local council in regards to consent forms, information packs, and chase-ups. If students still don't get vaccinated, even after being contacted, they get lost in the system and the follow-up stops there. As you can see, this is a lengthy process that could be more streamlined. But more than that, it can be more personalized and culturally appropriate for Indigenous communities. So in order to tackle these problems, we need to ensure that Indigenous Australian voices are continuously heard. We need to deliver a solution that is with direct consultation and employment of Indigenous Australians so that we can uphold the Indigenous sense of self-determinism and ensure community needs are responded to. So Serena, how are we going to fix this?
Yep, so next slide, please. Our solution is called HIT, the HPV Indigenous Immunization Task Force. The task force will be affiliated with the National Aboriginal Community Controlled Health Organization, or NACHO for short. Now, with regards to the strategies themselves, HIT will approach Indigenous HPV vaccination via two arms, a proactive arm and a reactive arm.
Can you tell me more about the proactive arm?
Yes, the proactive arm relies on education and community partnerships to increase HPV vaccination rates. From our research, which included an interview conducted with Foresee Council's immunization officer, we found that some of the barriers were poor awareness about HPV vaccination process, ineffective communication of vaccination date, cultural barriers, and local councils' engagement with First Nations people. We will be implementing specific strategies to deliver each of those solution areas.
It sounds like education is an important part of this. How will you specifically implement strategies?
Well, our strategies are driven by evidence-based practice. Educational materials and focused live sessions have been shown to improve knowledge for HPV vaccination. What's more, through live educational sessions delivered by local Indigenous health providers, as well as elders, we can allow an intergenerational exchange of knowledge about HPV vaccination and cervical cancer as well.
You've also mentioned deficits in knowledge of vaccination date itself. How will we address this?
HIT will implement an SMS and email messaging system, reminding both Indigenous parents and students about the vaccination date for first and second doses. The messages will be tailored for each community and are created by HIT.
So what happens if they still manage to slip through the cracks?
Ching, I'm just so glad you asked me that. Whilst the proactive arm will protect many, the research shows that there are still lots of challenges faced by the Indigenous population, and inevitably some will still be missed. These range from logistical factors, such as coexisting lifestyle impediments, to cultural factors, such as a lack of cultural safety or lucidity in the follow-up. To cater for the kids we miss, we have designed a reactive arm to our solution, which we've called the No Jab Left Behind program.
Sounds great. So how does it work?
No Jab Left Behind is a national follow-up protocol that will be coordinated by our HIT task force in conjunction with affiliates of NACHO. Local council immunisation officers will be required to forward the details of Indigenous students to the task force in place of the traditional follow-up discussed by Ching. If a student misses a school dose, the task force gives them a call attempting to organise a catch-up GP appointment. If there appears to be any problem at all, instead of giving up and being lost to the system, the task force then refers to the child's nearest NACHO establishment. These local centres can undertake a more personal follow-up in a culturally competent manner, providing further information and acting as a much friendlier steward for the child and their family.
So how do you all know that this will be such a hit?
Well, because it's necessary. There's currently no dedicated working group tasked with improving HPV vaccination completion in First Nations communities. We need a team that is able to roll out interventions targeted at the specific issues within the existing program. Importantly, by comprising Indigenous members, HIT aims to give Indigenous communities rightful ownership of healthcare, promoting self-determination and ensuring cultural sensitivity. Also, by leveraging existing Aboriginal community health organizations and services, our solution is resource efficient and modeled on community health infrastructure that has been shown to work well.
How much will this all cost?
We estimate it'll cost 1.125 million per annum to employ 15 equivalent full-time HIP staff members, as well as a 20,000 upfront cost, plus 124,000 per annum for our education program.
Okay, now walk me through how HIT will be implemented.
So let's say this project commences January 2022. We'll start by recruiting and training our task force staff, as well as liaising with Nacho about how this new team will work in concert with the existing organization. Soon after, we'll begin developing our education materials and organizing their various streams of distribution, such as through social media and elder-led community sessions. We're aiming for HIT to be integrated into schools by the end of that year, directly impacting Indigenous student HPV vaccinations from 2023 onwards. Of course, we'll have a data review annually to ensure everything is on track and adjust and improve as necessary.
What are some of the challenges and limitations you foresee?
Well, there may be a lack of engagement with HIT. However, because our task force comprises Indigenous people servicing their own community, a shared sense of responsibility and ownership over vaccine completion should hopefully mean our services are well utilized. Additionally, whilst we aren't directly addressing the issue of school absenteeism, our task force will be able to personally oversee timely receival of doses missed for any reason. Furthermore, although HIT requires ongoing funding, we expect huge cost savings due to less spending on cervical cancer management. And whilst our solution targets current and future Indigenous adolescents and not those who might have missed out previously, our framework is scalable, and with additional funding in the future, we can expand HIT to appropriately address catch-up doses for older age groups.
Sounds like this solution is here to stay. What else will ensure it remains viable in the long run?
HIT leverages intergenerational and local community ties, promotes resilience, and facilitates self-propagating educational and behavioral change. So it's a sustainable means of increasing HPV vaccination completion. Also, its impacts are easily measurable through tracking vaccine completion rates, and ongoing reviews means the task force can improve continually in line with community needs. It's more than just a one-hit wonder. Thank you.
Thank you, team. We will now pass over to the judges for question time.
Thank you so much for that energetic and really beautiful presentation. I loved all the icons that we used. It was very colourful and easy to follow. So thanks very much for that. So I had a question about how the task force would receive, I may have missed it, so apologies if I have, but if you could talk me through how the task force would receive the information about missed doses and how that relationship would be with the Australian Immunisation Register that obviously holds those records of HPV.
So I'm happy to open the discussion on this. So if you just, if we could just move the slide to that timeline. We had in terms of, the timeline of the current vaccine rollout. Yeah, so basically all we're doing is taking at the stage where the local council, the school immunisation officer would forward that information to the local council immunisation officer. At that stage where the information's forwarded, we also believe it should be forwarded to our task force, who can then take over specifically for those students that choose to identify as Australian Aboriginal people. So logistically, that's how that will run. And given that HIT is a kind of governmental organisation recognised as a health organisation, I think they'll also have access to the AIR, which conveniently has just become used for the record of HPV vaccinations, which hopefully will also improve our ability to aggregate that data surrounding the Australia's Indigenous children that are vaccinated.
Great, thank you.
I'll go next. I just had a question. You've gone for the big bang approach. You've gone straight to a national implementation model. Did you think maybe a pilot phase in a single jurisdiction or even area might give you some more insights before you go up to national scale. Just wondered if you threw that around as an idea, recognising that, in fact, because this is Australia, each state and territory rolls out their HPV vaccine program a little bit differently. So you've got an immunisation guide there that must be from one jurisdiction that uses councils, but others don't even use councils and probably have different timelines and different models.
I'm also happy to jump in here just because this is one of the areas I've looked at. So we've actually modelled our approach off after conducting a state case study on New South Wales. They had a really interesting program between 2012 and 2016 where they managed to, I think, reduce the gap by 4 percentage points. Within the space of 4 years, using these local immunisation health officers, which are kind of a similar inspiration to our program. Because we wanted to roll out a nationwide program, that's exactly why we decided to leverage the existing NACCHO infrastructure, because obviously our goals are a lot more ambitious. So that's why we thought it would be so much more powerful instead of trying to roll out all these, essentially what they did in New South Wales on a state level and expand it to national, which would obviously cost a lot more money. We thought it would be much more efficient and more powerful to have a network of local communities as opposed to one fairly impersonal national organisation. Yeah. I don't know if that answers all your questions. Does anyone?
No, I just wanting to check in that you'd thought about it, but there's certainly risks with going with straight into it at full scale. So.
Thanks, guys. And again, yeah, appreciate energy. That was, yeah, really bringing the energy. So well done. Very interactive too. So I had a question around evaluation. So it's always really important to check that these things are working and working the way we want them to. So I think you said there was audits, but yeah, I was wondering if maybe you could expand on that and what your plans would be to know, is this working in the way that we want it to? And what would you do if it wasn't?
Yeah, I'm happy to take that. So whilst we're on the slide, it's convenient. So generally with the model that we're using, there is always at the end of every calendar year, crosstalk between the local council immunization officer and the school's immunization officer. And every year the goal is to say, like, how did the program run this year? How can things improve? And then the local council immunization officer feeds it back to their team to see what can be improved for next year. So running with that model for our task force, we've got our HPV immunization task force HIT. And because they'll be in contact directly with the Indigenous students as well as the schools, they're able to directly get feedback year on year, both verbally and in terms of numbers, with access to the AIR to see, number one, are the people on the ground actually happy with the solution? Do they think it's culturally appropriate? What are things that we can do to improve? And number two, I guess in the long run, year on year, are the numbers actually increasing? And if not, then we have to go back through our feedback loop and see where can we improve this from here.
Yeah, and the beauty of that approach is the infrastructure regarding how to monitor the feedback actually already exists at a state level, given that all the previous data we have from the New South Wales program and the methodology they used in reviewing its efficacy. So I think we're not reinventing the wheel at all, which is often, I think, the foundation of a lot of the most powerful projects. So I think it's quite important to acknowledge that.
Thanks, well done.
Was that all the questions from the judges? Okay, as the judges finalize their scores, if anyone in the audience has any questions that they would like to ask HIT, please feel free to turn on your mic or write in the chat. I'll just move on and take it over, Jess.
No worries. Thanks, Minji. So that concludes all the finalist presentations for tonight. A really big congratulations to all the finalist teams who put forth some incredible proposals. Let's just have a quick 5 to 10 minute break as I pop the judges into a breakout room to decide on the winners of UCCC.
Okay, hopefully everyone's back after our short intermission. And welcome back, judges. I'm sure everyone's anxious to hear who the winner of UCCC 2021 will be. And I can assure you that the judges did have a really hard time choosing between the 5 teams. So I'll now hand it over to you, Lisa, Tamara, and Julia, to give some general feedback and announce our winners.
I'm going to start off by saying we certainly did have a very hard time picking the winner. There were aspects of each of your presentations that we adored, and we feel really excited about so many great minds applying themselves to this kind of problem and offering really great solutions. So thank you so much. And we do hope that some of you will consider a career in this kind of area in the future. Your presentations were polished and professional. We loved so many aspects of all of them. So it certainly was a really hard decision. So if you're not the winner tonight, I don't want you to feel discouraged or disheartened, because you've all shown great public health thinking and cultural awareness. And we really, truly appreciate the time and energy that you've put into your presentations tonight. So I'm going to hand over to Lisa, who's going to make the big announcements.
Thanks, Julia. And yeah, just to reiterate what Julia said, and on behalf of Tamara as well, you know, it's a real privilege for us to come along and be the judges tonight. You know, we spend our lives thinking about this stuff, and it is really refreshing to come to something and hear new and fresh ideas that challenge us. And so it was absolutely a very difficult decision. I'll be obviously hitting up lots of you to do my slide presentations for me, because wow, they're amazing. And I've just really had a fun night. So thank you very much. And just extend that what Julia said about really thinking about that public health career, whatever you decide to do, but just thinking about those aspects in all the work that you do is, you know, the community would benefit from that. So without further ado, and noting it was a very difficult decision, we'll start. So we've been tasked with giving the first, second and third, and so we'll start with those who we've awarded the third prize tonight, which goes to Catechist Consulting. So congratulations, excellent presentation. We loved the incorporation of the holistic approach and the manual, so that was fantastic. I'm looking, so yes, virtual. It's always weird, isn't it? Because it feels flat, like there's no noise, it's just me. And I won't keep anyone in suspense. So for the second prize, which was very difficult, we award that to the chronic overcommitters. So well done. The pharmacy aspect of your presentation was fantastic and really exciting for us to think about, as well as that sort of COVID learning. So thank you very much. Congratulations. And drum roll, the winner and the first prize tonight goes to 2 Shots to Stop Cervical Cancer. Congratulations, an excellent presentation, a presentation that was very much embedded in what's already happening and enhancing it, but also thinking about other interventions such as patient navigators in a new way, which was really excellent. So congratulations. And I have to say, you know, as a Torres Strait Islander woman, to hear you talk in the way that you did about First Nations leadership and embedding and the kind of cultural safety elements of your presentation were excellent. So well done. And congratulations to all the presentations tonight, though, as we said, fantastic, and to the winners. So I will hand back to the team and hear what is to come.
Thanks for announcing those, Lisa. Again, I'd like to congratulate 2 Shots to Stop Cervical Cancer, the Chronic Overcommitters and Catechist Consulting, as well as all of our finalists for making it to the top 5. It really is an achievement. So all finalists will receive an email within the next week or so with their certificates and further details on organisation of the prizes for our 3 winners.
So on behalf of the whole UCCC team, we'd just like to express our gratitude to, first of all, our judges who have taken time out of their really busy schedules to be here tonight. Thank you to all our finalist teams and also everyone who participated in UCCC for all the hard work that has gone into your incredible proposals for the competition. Before we finish, actually, we'd appreciate it if everyone could maybe turn their cameras on so we can take a group picture. If you don't wish to have your photo taken, that's totally fine as well. Just feel free to keep your cameras off. So just take a screenshot.
Perfect, thanks Jess. So if anyone has any further questions, please don't hesitate to contact us via email at uccc@yasi.org.au. I'm sure you've all got that by now. Or find us on Facebook. We look forward to welcoming you all back next year for UCCC 2022. Thank you so much, everyone.
Thanks, everyone.
Good job, everyone. Wonderful presentation.
Congratulations,
Thank
everybody.
you. Congratulations.